us, the pulmonologists, surgeons, social workers, nutritionists, and we decide, is transplant in your near future? Are we early, again, within the window? If we're within the window, some of the factors that help us decide that is, are you on oxygen around the clock? Is your lungs not functioning to the point where you're able to exhale and you're now retaining carbon dioxide? Is the pressures in your lungs elevated? These are factors that are certainly indicative of transplant and ready for listing. As I alluded to last time, being too sick is always a concern. And again, far and few cases, but certainly we'll get patients presented to us on life support. Are these patients too sick for transplant? And that's always something that we always worry about. So mechanical ventilation or life support is certainly, patients are sick enough for transplant, but are they too sick? And that's a case-by-case scenario. In 2005, the lung allocation score was implemented by the Organ Procurement and Transplantation Network, changing the system from one primarily based on waiting list time to one allocating donor lungs on the basis of a score calculated from multiple variables. And we'll go over those variables in a second. But basically, imagine if you needed a lung transplant and you just had to wait in line in order to get that transplant. It didn't matter if patient 1 was a little healthier than patient 2, you still had to wait. So therefore, we had an unexpected higher death rate on the wait list. So the lung allocation was derived, and it was derived from a prediction of benefit. The main objectives were two things: prioritization of candidates based on urgency while avoiding futile transplants. 2, reducing the number of deaths among potential and actual lung transplant candidates on the wait list. Some of the factors that we use to calculate the score are, well, let's take a step back. The lung allocation score took a number of years to put together. They looked at factors that would predict wait list survival, and they looked at factors predicting post-transplant survival. And these are some of the variables they looked at. Forced vital capacity, it's obtained from the breathing tests that you perform again in clinic. Some of the heart pressures that we monitor or identify during evaluation through echocardiogram. Are you on oxygen, and if so, how much? Your age, your weight, your BMI is a huge factor. If you're underweight, it certainly predicts you're sick. But if you're overweight, it increases your mortality, and we'll talk about that a little more. Your functional status, how far can you walk? If you can't walk far, your disease is pretty advanced. The diagnosis, it depends. Some diagnoses portend a slightly increased poor prognosis than others. So cystic fibrosis in the middle. How far can you walk, that 6-minute walk test? Are you on life support? If so, is there a chance we can get you off life support? If not, it predicts the wait list survival. Evidence of diabetes. Do you have diabetes at the time of listing? And then some of these variables overlap. By putting these variables together, if you're ready for transplant, we put it into a calculator and predict a score. This score will put you on a wait list. The higher the score, the sicker you are. So it certainly benefits our patients who are quite sick, and they don't have to wait as long. Once this score was implemented, there were a number of physicians who thought, is this score benefiting my patients? So for example, cystic fibrosis patients, physicians, or pulmonary hypertension physicians. Does this score affect in a negative manner my patients? So last year there were a group of physicians internationally as well as locally in the US who looked at this score, particularly in the CF population. They looked at 704 patients between the time frames of 2005 and 2009. And basically what they found, looking at a number of variables, it did help their patients who had cystic fibrosis. It was associated with almost a 69% reduction in risk of death because of this score. So in conclusion, certainly benefits our patients with CF. Now, looking at organisms that our patients harbor. Despite initial studies from years ago, poor post-lung transplant outcomes were identified with patients who had multi-drug resistant Pseudomonas. However, more recent studies over the last 5 to 10 years, this has not been shown to be true. It does not affect the post-transplant outcome. And physicians, so how did they identify this? There was a group of physicians who did a fairly large study at the University of Toronto and Duke. They looked at a little over 100 patients with CF, and they compared the patients who had highly resistant organisms versus organisms that were sensitive to a number of antibiotics. And what they found were that even though patients who had pan-resistant organisms, they had a slightly higher complication rate with infections post-transplant, but their outcomes were certainly in par with the rest of the other diseases we transplant. So in conclusion, multi-drug resistant Pseudomonas is not a contraindication of transplant. Another species we identify in our CF patients is Aspergillus. It's a fungus. Approximately 20% of our patients are colonized. The patients who are colonized and go on to transplant, they have a slightly higher risk of post-transplant airway complications. But again, this has not been shown to affect outcome to the point where we need to consider this as a contraindication of transplant. So certainly these patients do fairly well. And certainly with the antibiotic and antifungal regimen we have, they do okay. Next, however, is our bug of concern, Burkholderia cepacia complex. Under this complex, there's a number of species, and the one that worries us most is Burkholderia cenocepacia. This was formerly known as Genomavar 3. This organism is unfortunately associated with a substantial increase in mortality within the first year. Overall consensus across the US and internationally is it's an absolute contraindication. It's number of centers. However, majority of centers will evaluate each case by case and will not exclude these patients with this species unless fully evaluated. I think Elika talked about non-tuberculosis mycobacterium. 10 to 15% of our patients harbor these organisms. Mycobacterium avium complex, being the most common, does not pose a problem to transplant. However, Mycobacterium abscessus does. The reason why it poses a challenge is it's hard to eradicate, and if it is lingering around in the post-transplant period, we have a fair amount of infection rate within the chest cavity, leading to infections of the lung, the surgical site wound, and as a result, some centers consider this bug to be an absolute contraindication. However, again, case-by-case basis. There are situations you can eradicate this organism, and as a result, centers will continue to consider these patients for transplant. Diabetes. CF-related diabetes affects approximately 19% of our adolescents and 40% of adults over the age of 40, with increasing likelihood in our female population. Earlier studies showed that there were some complications post-transplant. However, recent studies have shown that there's no associated complication in the setting of well-controlled diabetes and no outcome changes. So therefore, diabetes does not exclude transplant as a possibility. Our GI tract, again, we'll talk specifically about 3 topics: gastroesophageal reflux disease, malnutrition, and liver disease. Gastroesophageal reflux disease has a prevalence of approximately 75 to 90% in our post-transplant period, as opposed to GERD being prevalent in only 50 to 75% of lung patients with other causes of end-stage lung disease. The reason why we're so concerned about esophageal reflux disease is that it increases our risk of post-transplant rejection as well as chronic rejection. This was first identified in 2000 at Duke University. They had a patient who had a progressive decline in lung function, substantial workup, no evidence of rejection, infection, But they did find that patient had significant reflux disease to the point where the esophagus was inflamed, patient had chronic symptoms. The treatment in the general population for acid reflux is a Nissen fundoplication. Basically, they take a stomach, the stomach, and wrap it around at the base of the esophagus, creating a valve. And that patient, particular patient, underwent this procedure, and his lung function continued to improve after. And since 2000, there have been a number of studies that shown that uncontrolled acid reflux in the post-transplant period lead to graft dysfunction. So it's not uncommon to see that our patients who have bad reflux disease go on to get a Nissen fundoplication in the immediate post-transplant period after lung transplant. Certainly medical therapy helps, your acid reflux therapies, changing diet, but the mainstay treatment is a surgical procedure, unfortunately. Malnutrition. Identified or defined as being underweight with less than, your BMI being less than 18.5 kilograms per meter squared, or hypoalbuminemia, meaning basically albumin measured through the blood. Current selection guidelines do not mention underweight as a contraindication of transplant. On the other hand, obesity is a BMI of greater than 30. But when we, physicians in the transplant community, looked at these patients who were underweight, they certainly had a higher risk of death after transplant in single center studies. So a group of physicians out of Columbia University did a retrospective analysis of our UNOS, of our data called the UNOS database over an 8-year period. And they focused on 3 diseases: CF, COPD, which is a smoker's disease, and ILD. They evaluated just shy of 6,000 patients. And what they specifically looked at is data for the underweight recipients. 50% of those patients were made up of cystic fibrosis patients, and the other 50% were COPD. The adjusted mortality rate for underweight patients was 15% greater than patients who went on to lung transplant with normal weight. So certainly higher. Now, if you looked at that same group of patients who were underweight and looked at the CF individually and COPD patients, the CF patients had an approximately 25% greater risk of mortality than the normal weight patients, and COPD patients 18%. So, comparing these outcomes for underweight versus obese patients only have, not only, but still have a 15% increase in mortality, substantially lower than underweight. Other studies have confirmed these findings. In addition, they've concluded these individual statements hold true. If your total protein measured through blood is low, there's a postoperative increase in pulmonary infections. If your albumin is low, less than 3 grams per deciliter, there's an increase in death. So the association between hypoalbuminemia and post-transplant mortality was identified highest in our CF patients and interstitial lung disease patients. So in conclusion, Laura's role in our pre-transplant period is certainly crucial to a good outcome. So I think the advice that she holds true with early PEG tube placement, optimizing nutritional status is certainly extremely important when you get to transplant. And then if you're underweight, we certainly consider deferring transplant till your nutritional status is improved. Liver disease. Approximately 4 to 10% of our CF patients have cirrhosis resulting in synthetic dysfunction. If there's evidence of significant disease, some of our patients may be evaluated for a combined transplant, liver and lung. However, if you have evidence of cirrhosis, that doesn't particularly define or mean that you need a liver transplant as well. So if you have evidence of cirrhosis but the synthetic function is still working, meaning you're able to perform clotting factors, your bilirubin is low, sole lung transplant is still an option. So that's important for us to know CT scan of the abdomen, blood work to identify your liver function. Sinus disease. Actually, our director, Dr. Weil, did this study back in 2008 when he came here to Stanford. They looked back at chart review between 1988 and 2005, right before he arrived. And what they did prior to his arrival was that every CF patient who underwent transplant had a sinus surgery prior to lung transplant, because what they were trying to avoid is the organisms that harbor your lungs certainly harbor your sinuses. So if they take out the lungs, they don't want those same organisms to affect the new lungs. So they performed sinus surgery to try to eradicate all the organisms living there. What they found was, despite surgical intervention, still 87% of patients were recolonized with the same organisms post-transplant, and their outcomes were not any different than the data we collected after. So certainly there's no indication for sinus surgery to become a transplant candidate, but certainly if there is evidence of severe disease, Dr. Moabir and his team would certainly consider sinus surgery. And then after transplant, we may consider sinus surgery if you're having recurrent respiratory tract infections. Malignancy. Pre-transplant, our patients, CF patients who are non-transplanted, don't have such a high risk of malignancy. However, in our post-transplant period, irrespective of CF or not, there's a slight increase in chance of malignancy, cancer. And the two things that we worry most about is skin and colon cancer. In our CF patients, they've did a retrospective analysis of over 20 years, recently published in 2009. And what they found was that CF patients in the post-transplant period certainly had a higher risk of colon cancer, almost tenfold. They had only 19, expected was 1.1, but what they found was 19, observed cases were 19 higher than the expected. So again, almost a 19-fold increase in colon cancer. It's not clear why this was identified, but certainly in the post-transplant period, we're more diligent about having annual colonoscopies if it's indicated to evaluate for colon cancer. Skin cancer, we evaluate for routinely, annually through our dermatologist. So in conclusion, lung transplant remains to be an option for our CF patients with end-stage lung disease. Long-term outcomes remain superior to those for patients with other lung disease amenable to the transplant. And despite the multiple comorbidities associated with wrong statement. So possible areas for future research to improve transplant outcomes include surgical technique, organ procurement and preservation, and postoperative management in the ICU. Questions?
One of the things you talked about is the new lung allocation score, and obviously the higher the score puts you higher on the list. Is there any data to suggest that the higher the score, maybe these patients have a higher mortality post-transplantation?
Certainly. There's a factor towards patients who have, the higher the score, are they at risk for not doing well post-transplant? And we have that continual evaluation on a day-to-day basis. If they're becoming more and more deconditioned and are not able to do daily activities of living, because the last thing we want to see is that if our patients are too sick to undergo just daily activities living, they're sitting around in bed because they're too sick, their post-transplant period is going to be very difficult to rehab, get up and walk around, because now they're dealing with muscle deconditioning, malnourishment, and as a result, yes, there's certainly an increased risk for post-operative bad outcomes if your score is high. But again, we have a day-to-day evaluation for each patient with a high score, to assess that patient is now too sick for transplant. So, yes, in a short answer, yes, there's certainly an increased risk, but we would not pose our patients to poor outcomes if we think they're too sick for transplant.
On your talk, you also commented that CF patients tend to do better for survival, 1-year survival, post-transplantation. Can you explain to the group why?
I think it has to do with age. I think majority of our patients, and it's not clear, I asked Dr. Weil, who's our director, but I think it has to do with age, and certainly as we get older, more and more complications happen, whether we transplant a 50-year-old when they become 60, do they have heart disease now becoming a problem in their life? So certainly I think age is a huge factor of the improved outcome in our CF patients.
Last question. Can you talk about the lung allocation score and the factors associated with giving the patient that score, such as FVC and oxygen requirements at rest? Because in most of our CF patients, FVC doesn't really reflect the severity of their disease, and oxygen
Yeah.
at rest.
And so when they looked at the number of variables assessing when they looked at a number of variables required to calculate this score, unfortunately, FEV1 was not part of that variable to change their outcome. And so they didn't include that in their variables that they looked at. It just had to do with the way they did the analysis, and it didn't reflect a change. So FEV1 was not included, FVC was. Does that sort of answer the question?
Yeah, and does that prompt you to list CF patients maybe earlier than non-CF patients?
No, due to the fact that FEV1 was shown through a number of studies in our CF patients to predict poor outcome and not FVC, with or without a transplant. I think somebody had a question in the back.
Under the psychosocial evaluation, has there been any studies done with either ethnic or cultural differences to see if that variable is important?
No. It doesn't seem to, we transplant all cultures or ethnicity, and there hasn't been any outcomes to show that despite ethnicity, it changes any postoperative outcomes.
So everyone, thank you. This concludes the actual adult section. I think there was a great panel of speakers, even for me, very informative. And as many times as you hear it, you don't hear it enough because you build on it. And I guarantee you next year there'll be something innovative, something that has changed. And the one thing that we hope when we come back next year is that we'll see an even better improvement in survival, as we have seen consistently every year that we've come here. So thanks to all the panel speakers. And please fill out your evaluation forms. Thank you.